Now, thank you all for coming to the Clinical Epidemiology Health Services Research Round at Toronto General Hospital. Today, I'm very happy to introduce to you Dr. Ewan Goligher, who is an assistant reading this. I haven't memorized his credentials. He's assistant professor in the Interdepartmental Division of Critical Care Medicine at U of T and a scientist here at TGHRI. He attends the Medical-Surgical Intensive Care Unit here at Toronto General Hospital. His research program focuses on adverse patient-ventilator interactions and their impact on patient outcomes. He's a clinician and a clinical epidemiologist, and I know from having seen some of Ewan's R code that if none of that works out, he'll make a pretty decent statistician as well. Haha. He's here to talk about a topic which is great interest to me, Bayesian analysis in clinical medicine. And it's a very good title, which I may steal myself for a talk I give on this topic now and again. Is Bayes better? The logic of statistics and the case of ECMO. And I worked on some part of this with Ewan, and I'm always really interested to see the bigger picture, because as a statistician, I feel like my lens is quite narrow, and when I see things put into context, it's always quite illuminating for me. But that's all I have to say. So Ewan says that if you have questions along the way, ask them, but if they're kind of general questions about Bayesian inference, and not about specific things he's saying, save those to the end. And thank you.
Great. Thank you, George. It's really a privilege and a pleasure to join you for rounds today. I have to say I'm completely indebted to George because he's actually taught me a ton about Bayesian statistics while he was on vacation in Sweden last summer. He and I were corresponding. I was making him work on vacation, but really, it's always a real pleasure to collaborate with George and with others here in the BRU. And it's kind of interesting because I remember when I was a first-year undergraduate student, we were all invited. I was at UBC, and we were all invited to a lecture given by a statistician about why we should pursue a career in statistics. And I never went because I thought that's horrible. Maybe I shouldn't say that. But honestly, now that I know a little bit about statistics and work with people about Georgia, I think these are such fascinating and important and intellectually stimulating areas to work in. And so for those of you who are statisticians, I congratulate you on your career choice. So I want to talk today about some lessons and insights I've gained about the Bayesian perspective on data analysis based on some work that George and I did together with some others on a randomized trial of ECMO for severe ARDS, and we were fortunate to have published in JAMA in the fall. So I want to spend some time explaining sort of the mechanics of Bayesian analysis. I apologize to those of you who already have expertise in the area. Some of it might be basic. And then just explain how we applied the framework in the paper and where these kinds of approaches might be useful in analysis. And I welcome your comments, your critique, and thoughts. These are my disclosures. This company, Gaduga, makes ECMO equipment, and I have received fees and support from them in the past. So our goal, as I said, is to understand the basic differences between frequentist and Bayesian frameworks, to review how one might go about doing a Bayesian analysis, and to appreciate circumstances under which Bayesian and frequentist analyses might actually disagree. So this is ECMO. I'm not sure if any of you have ever dealt with ECMO or cared for patients on ECMO, but ECMO is basically a form of extracorporeal life support where when even our advanced techniques for mechanical ventilation fail to sustain gas exchange and the patient's life is under threat, the patient is placed on ECMO, and this involves putting small hoses, or what we call them large cannulae, in deep vessels that allow us to remove blood from the venous system, oxygenate it, clear CO2, and then recirculate it back into the venous system. And from there, it goes through the heart. So you're really no longer relying on the lungs at all for gas exchange. There's different kinds of ECMO. The particular form of ECMO I'm illustrating here is called veno-venous ECMO, which is where you're just oxygenating venous blood and returning it to the venous circulation. People also do veno-arterial ECMO, which supports not only the lungs but the heart, but that wasn't really what was under study. And the use of veno-venous ECMO for severe respiratory failure has just massively taken off in the last 10 years. You may remember about 10 years ago, there was a pretty significant worldwide pandemic of H1N1 influenza. And it was really, there were many, many very young people, particularly pregnant women, who had life-threatening hypoxemia, and people were resorting to ECMO to sustain life. And up until that point, every trial that had been done of ECMO suggested severe harm. So this was an act of desperation at the time. But the patients did surprisingly well, and it really became kind of cool to do ECMO, as you can see from the international case numbers over the last 10 years, really taken off. And our numbers here at Toronto General, were really the ECMO center for the province, would reflect the same kinds of trend in growth. So this was an area of interest. And of course, as with so many things in medicine, sometimes the uptake outstrips the evidence. And so we were interested to try it and study the benefits of ECMO in a more systematic way in a randomized trial. The benefit of ECMO was quite controversial, or has been quite controversial up until last year with the publication of UHN, which is the trial we'll talk about. There have been 3 large studies of ECMO. One of them was a randomized trial, and the other 2 were kind of large propensity-matched observational studies. And all of them suggested a fairly consistent signal towards benefit. But of course, given the limited kind of inferences you can draw from observational data, and given some serious issues with the previous randomized trial of ECMO published in The Lancet in 2009, the conclusion of a guideline that I was fortunate to be part of was that there really is insufficient evidence to make a recommendation around the use of ECMO in the management of severe ARDS. And when UHN was published last year, it was awaited with a lot of anticipation in my field, because it was thought that this would be finally the trial that answered this question. And in fact, UHN was stopped early for futility. This was a trial that commenced back in, I think, 2008. It was planned to enroll and randomize 330 patients. And at around the late 9-year mark, they met their sort of pre-specified criterion for futility after randomizing 240 patients. And nevertheless, despite the early stopping for futility, there was a pretty marked and impressive difference in mortality, where the ECMO group had an 11% absolute risk difference in mortality, and it was this close to being statistically significant under the conventional approach. And so it immediately became massively controversial. Did UHN suggest benefit or not? Particularly when the editorialists in the New England Journal concluded on the basis of this trial that routine use of ECMO is not superior to rescue ECMO. There were a lot of people who I work with who vehemently disagreed with this, but of course they would be simply written off as enthusiasts. So there was a lot of controversy about how to interpret this trial, and this occasioned our Bayesian analysis. Just actually earlier this month, a conventional meta-analysis combining the previous randomized trial with UHN was published, showing an overall beneficial effect. But again, the level of evidence that this was characterized as was only moderate quality because of major design issues in the previous randomized trial with co-intervention and a few other concerns. So we considered a Bayesian analysis for UHN. Basically, the basic appeal of the Bayesian analysis is that rather than estimating the probability of obtaining the data that you observed, which is sort of what a p-value is, more or less, it aims to estimate the actual probability of treatment effect. And of course, this is the kind of information we actually want at the bedside when we're making decisions. And secondly, one of the important useful aspects of Bayesian analysis is that it allows you to incorporate prior information, insights that you have from previous data about your own kind of belief about the effectiveness of the therapy. You can quantitatively incorporate that information into your interpretation of the trial. And of course, this is important because so often when randomized trials are published, people's reactions are twofold. They're either, I already knew that, or I don't believe it. And evidence doesn't always change our thinking, and for good reasons. Sometimes we have really good reasons to believe that certain things are true, and we're quite confident about those beliefs. And so it would take a lot of evidence to shape those beliefs. And Bayesian analysis allows you to quantitatively assess the degree to which new data should influence or change your beliefs about treatment effect. Of course, we're not familiar with Bayesian analysis because it's not widely used, but nevertheless, a number of important studies have been designed and published using a Bayesian framework, including a couple of trials in major clinical journals. And the FDA has actually published guidance on how to use a Bayesian framework in the design of a trial, particularly for medical devices where sample sizes can be small. And so there's increasing regulatory acceptance and academic acceptance of the technique that has some legitimacy from that standpoint. So how does Bayesian analysis work? Well, first of all, you specify your prior. This is your beliefs about the plausible distribution or range of values for treatment effect, given what you already know and believe. And the skeptical prior might be centered around no effect. You combine this with the data represented as a likelihood function, and a little bit more about what that is. And then you combine these two distributions to compute a posterior distribution, which is basically an updated plausible range of values for treatment effect, given your prior and the data that you obtained in your study. And the results of the posterior distribution can be summarized either as a median and 95% credible interval, or it can be represented as the probability of a treatment effect of interest. So let's say you're interested to know what the probability is that the relative risk is less than 1 based on your posterior distribution. You can estimate that probability from the area under the curve. If you think that some more larger treatment effect is your minimum clinically important difference, you can estimate the probability of that effect. And so this becomes a very flexible technique for interpreting results that allows you to build in interpretations of what's clinically relevant or clinically important, which I think is a really important feature of the Bayesian approach. All right, so now I want to go on for a few minutes about why I'm no longer a frequentist, and sort of some of the reasons why perhaps we should reconsider our usual thinking about statistical analysis. And it's interesting to me because I find that when I explain these concerns to clinicians, they sort of automatically jump aboard and say, yeah, I totally see the appeal. But whereas some of the statisticians I've had conversations with seem to be much more entrenched in the camps to which they have been, into which they've been indoctrinated either way. So I'll be interested to see the discussion in the room about where people are coming from on these issues. So I think there's a certain logic. There is, of course, a certain logic built into frequentist statistics, and it generally takes the form of a deductive syllogism with two premises and a conclusion. And the first premise is generally what we represent as the null hypothesis. The idea, in the case of ECMO, might be that ECMO has no effect on mortality. That might be the null hypothesis. And the second premise is essentially the p-value. It's the probability that you would have observed an association as or more extreme than what you did observe, assuming that the null hypothesis is true. That's what the p-value is meant to represent. And by convention, one way, by whatever fortune, most of the time people think as the cutoff for significance is around 5%. And so if the p-value is low enough, then you can conclude that you have sufficient evidence to reject premise one, and therefore that sort of entails that ECMO probably has some effect on mortality. That would be the alternative hypothesis. And so the statistical question under a frequentist framework is really, what's the probability of the data given the hypothesis? And that's, of course, actually the reverse of what we really are interested in, which is what's the probability of the hypothesis given the data. This logical structure necessarily builds in a kind of dichotomous yes or no answer. It's not necessarily amenable to a more continuous probabilistic assessment. And it's not exactly clear what you're supposed to do or conclude if you find that the p-value isn't low enough to fall below 5%. You know, what is saying the null hypothesis is not probably false the same as saying that the null hypothesis is probably true? Clearly not. That's not the case. And this is why it becomes so difficult to determine exactly what to do with the results of a trial like Eolia, where the p-value is 0.07. It's approximating something that we might call statistical significance. It's not clear whether you can reject the null hypothesis there or not. And even if you do accept 3 and reject your null hypothesis, does that mean that you've demonstrated that ECMO actually has clinically meaningful or relevant benefit? Again, that just doesn't factor into the logic of the usual way of doing statistics. There is, of course, an insistence in this framework on trying to employ deductive rather than inductive logic. And this is naturally because deductive logic allows you to draw much firmer conclusions than inductive logic can. Deductive logic logically entails the truth of the conclusion, whereas an inductive formulation only makes the conclusion probable. And a couple of sort of typical examples of inductive and deductive arguments are, for example, when you say every raven in a random sample of 32 ravens is black, obviously you can't conclude that every raven everywhere for all time is black, even though it seems like it's probably true given the fact that you've never seen a white one and you've looked at a lot of ravens. On the other hand, if you were to simply find that one raven in your random sample was not black, then you could confidently and truthfully falsify the claim. And so the deductive conclusion of falsification is naturally much stronger than the inductive inference. And this, I suspect, although I haven't actually taken the time or been able to dig up documentary evidence to support this speculation, that the frequentist framework insistence on deduction is sort of a function of the philosophy of science articulated by Karl Popper, who argued that falsifiability was sort of the fundamental defining feature of a scientific hypothesis. It was sort of what demarcates scientific work from non-scientific work. And Popper argued that every genuine test of a theory is an attempt to falsify it or refute it. And I think, of course, he's onto something important in the sense that really falsification is really ultimately the thing that we can confidently do. Confirming, we have to, a hypothesis has to be held with much greater tentativeness. But nevertheless, when we're trying to use science in the real world to decide whether to act or not, we are really trying to confirm an idea so that we can confidently act and tell patients we're benefiting them. So I think there's a limitation to this theory of what science is in actual practical everyday life. The other criticism I have of frequentist paradigm is the actual meaning of probability in frequentist terms. Frequentism gets its name because under this framework, probability is defined simply as the long-run relative frequency of events. It has a very concrete empirical character to it. Often when we talk about probabilities in the ICU, for example, a family will ask me, well, what's the probability that my loved one is going to survive or recover from mechanical ventilation? They're not asking me, well, if my loved one was here 100 times, how often would they actually recover? They're asking, no, in this one instance, how confident am I? We use probability in a way to describe confidence in belief. But for a frequentist, that's utterly anathema. It's the long-run relative frequency of events. So this is why frequentists, when they're talking about statistics, like to talk about many coin tosses coming up heads. Basically, the probability would be the proportion of heads in an infinite number of tosses. But then when it comes time to talk about the probability of the result of the next coin toss, it gets much harder because that's not a long-run repeating event. So, for example, frequentism can't really be used to talk about the probability of another world war because that's not a long-run repeating event. That's a single instance. Or the probability that my hypothesis is true. Again, under frequentist terms, talking about probability that way doesn't make any sense. It's not measurable. And then, of course, there's this other issue, which I think we all appreciate, regardless of whether we're Bayesian or frequentist in our inclinations, is that often people are far too arbitrary in the way in which they decide what counts as statistical significance. And the interesting thing is that R.A. Fisher, who was one of the first to sort of come up with this method of calculating the p-value himself, did not have any notion of an arbitrary level of significance. He thought nobody should work with a fixed level of significance, but rather give your mind to each particular case in the light of the evidence and ideas. So for Fisher, a p-value wasn't something that if it was below 0.05, you had the truth, and if it was above 0.05, it was false. It was something to be interpreted as a level of evidence. It was actually Nyman and Pearson who took the idea of the p-value and turned it into this dichotomous issue of 0.05. And of course, there's been proposals in the literature by John Ioannidis and others to make a much more stringent threshold for p-value to address this issue. But the point is, we all recognize that just stipulating 0.05 is sort of weird and arbitrary. It doesn't make sense, even though we're all doing it all the time. So some have suggested that confidence intervals might be the solution to the problem. And so, for example, if you specify a confidence interval, it's no longer just this arbitrary dichotomous significant, non-significant. You're giving a sense of where the effect might lie. But in fact, and this is something as a non-statistician that I've come to appreciate, having read and thought about these things, confidence interval is much more difficult to explain in frequentist terms than one normally thinks. So there are 6 statements on this slide. This is derived from a very interesting survey study. And you don't have to put up your hand or give your answer or something, but if you had to pick one of those statements to accurately represent what you think a confidence interval means, then just in your head select it and decide whether you agree with at least one of them or not. I'll give you 20 seconds to do that. So, all right, anybody need more time? All right, so this is the results of the survey. You can see that there were some differences between first years and master's students and researchers in terms of what they thought the right answer was. But here's the interesting thing is that none of these answers are correct. And if you really understand what a confidence interval is, you'll say no to all of them. But I have to admit, if I hadn't spent time reading about this, and I've taken several statistics courses, I would have assumed that perhaps a couple of these are accurate representations of what a confidence interval is. The actual sort of correctly worded interpretation of a confidence interval is if you were to repeat the experiment over and over, then 95% of the time the confidence intervals would contain the true mean. So people point out that what this means is a single interval actually doesn't contain any information. It's only as you repeat the intervals over and over that they start to contain some kind of information that describes where the effect might lie. And so when people read confidence intervals, actually what they're doing all the time is interpreting them on Bayesian terms, as I'll explain momentarily. In our heads, we just cannot help but think like Bayesians because frequentism is just too difficult and abstract. And I'd say it's nonsensical in this case, a confidence interval not telling you anything. All right, so I've ranted a little bit about frequentism, and you can correct me where you think I might be wrong. But let's turn now to just quickly explain the logic of Bayesian statistics. It is inductive in most formulations, although it can be formulated in a deductive type of fashion. Essentially, your observations entail a distribution of possible values for the relative risk. That's what's represented by the middle distribution there called the likelihood. And in view of that, and in combination with your prior beliefs, if you have any, the probability of the relative risk or some other parameter for effect or association take some value is whatever you might compute that probability to be. And of course, doesn't have the strength or confidence of a deductive inference, but it allows you to say, based on the information that's available, this is how confident I can be about what I'm claiming to be true. And of course, the approach is based on Bayes' rule, where here B is the probability of the hypothesis and A is the probability of the data. And you basically go from the probability of the data given the hypothesis to the information that you actually want, which is the probability of the hypothesis given the data. One of the really compelling things to me about Bayesian statistics is that is encapsulated by this idea of the likelihood principle. Under Bayes', whereas in frequentist statistics, the data are treated as a distribution and the parameter you're trying to estimate is fixed. And this is why you get type 1 and 2 errors, because the parameter is fixed. In a Bayesian framework, the data is fixed and the parameter that you're trying to estimate is regarded as a distribution. And so that means that when you're estimating what the parameter might be, you're not trying to make a claim about, oh, it's this one specific value. You're saying, based on the information I have, it takes this possible or plausible range of values. And the data that you, or the probability distribution that you generate from your data, the likelihood, under what's called the likelihood principle, contains all the information the data can provide about the parameter. And so one of the interesting implications of this is that the information that you obtain from the data is independent from the path by which you took the data. And the really important and relative case is sort of trial sequential monitoring and repeated hypothesis testing. So the interesting thing is, if you do a randomized trial and you have no pre-specified interim analyses, the stringency of your p-value at the end of the trial does not need to be as conservative as if you had 10 interim analyses that you pre-specified as part of your design. And what that means is that the results of the amount of information you actually collect from the data actually depends on how you acquire the path by which the data was acquired and handled along the way, which actually, when you think about it, is really weird. The data is the data is the data. The information that's there. Frequentism, people build in this criticism of frequentism that I don't know if I understand it perfectly, but say that the results of under frequentist analysis come to depend in part on the intentions of the investigator, because and it's exemplified by this kind of repeated hypothesis testing during interim analyses. We're under a Bayesian framework because all the information is contained in the data itself. There's no concerns about repeated hypothesis testing, and this becomes the basis for which Bayesian analysis is very useful as a tool in adaptive trial design. And this, a reference here below by Don Berry in Nature from many years ago, is a beautiful, very introductory description to how Bayesian analyses inform trial design. And I like this figure here where he shows how as you accumulate events in your trial, successes or failures, this binomial distribution gradually takes shape. And so you can see that, and with each step, you are allowed to look at your data and see where the distribution lies and see what kind of information you're accumulating, such that once the posterior probability of your hypothesis being true or false becomes sufficiently high or low, you are allowed to stop the trial, and there's no concern about these interim monitoring. So this, to me, is one of the really compelling features of the way Bayesian analysis lends itself to adaptive design. So probably the most controversial feature of Bayesian analysis is the way in which it incorporates priors, because people criticize Bayesian analysis for being subjective because, oh, you can just specify whatever prior you want, and then you get the result that you want. And of course, one of the important features of an actually well-designed trial is that it will be the posterior will be relatively robust to the prior when your trial is sufficiently informative to really answer the question. So there are kind of standard frameworks that have been described for developing priors in Bayesian analysis, and I found the approach described by David Spiegelhalter, who I understand is sort of one of the grandfathers of Bayesian analysis, a British statistician, to be very helpful. And he basically argues that a good trial should be, if it's going to be negative, should be negative enough to convince a reasonable enthusiast. And if it's going to be positive, it should be positive enough to convince a reasonable skeptic. And with that very reasonable notion in mind, basically said that you can design your priors to express skepticism around the effect size used to plan the trial. So in the case of Veolia, as we'll see, the effect size used to plan the trial was a ridiculous 20% absolute risk reduction in mortality. And as you know, so often those effect sizes are chosen not for sort of what you really believe to be true, but simply what makes your trial feasible. But in the case of Veolia, then you would basically, to express skepticism, you'd say, I think the chances of achieving an effect size of absolute risk reduction 20% is very low, less than 5% would be sort of the standard Spiegelhalter approach to designing a skeptical prior. And the skeptical prior is centered on zero effect, so that representing the fact that most likely value is no effect. Whereas an enthusiastic prior would be centered around the effect size used to plan the trial and take your sort of prior belief to be the probability of having no effect or harm being very low at the outset of the trial. And so this, if your results, your posterior probabilities are consistent to convince either a reasonable skeptic or a reasonable enthusiast with these priors in mind, then you have enough data to sort of draw confident inferences and say that you've sort of bringing together divergent minds in the field. So this is one framework for specifying priors that sort of, I think, that lends some objectivity to the process. One of the other really important features of a Bayesian analysis is that when you're designing the analysis, you need to specify exactly what you consider to be an important effect. So, for example, if your priors are centered around an absolute risk difference of 0%, and you show that the probability that the absolute risk difference is greater than 0%, it's still not that meaningful if the true absolute risk difference is like 0.1% or 0.05%. You need to have some threshold in which you say, okay, this is actually a real, meaningful, clinically relevant effect. And so this becomes a very important decision in the design of your analysis, but I think it requires, again, another form of clinical judgment. But again, it's very important and very relevant because clinicians have to make these kinds of judgments in real life all the time. And so by building this into your analysis, you make it more informative to clinical decision making. And then, as I said earlier, you can report the results of your Bayesian analysis either as a probability of a particular treatment effect from the arrow end of the curve or based on a credible interval. All right, so that's a little bit of background. I basically want to spend a couple minutes explaining how we specify priors for the Bayesian analysis of the EOLIA trial. So this was a complicated problem, and part of the reason it's complicated is because ECMO is one of those things that generates a wide spectrum of beliefs. There are some people who strongly believe in the technique. There are other people who are extremely skeptical given the cost and resource-intensive nature of the technique. And so when we were designing priors, we wanted to represent the full spectrum of possible ranges of belief, but secondly, also to try and represent people with intermediate degrees of belief or skepticism in order to help the reader of the study sort of decide where they themselves would land. And so the first thing that we did was to specify a minimally informative prior. This is the one represented by the flat blue line. And this prior essentially is equivalent to having no prior information about treatment effect. And if you combine this minimally informative prior with the data that you observe in the trial, it basically turns your confidence interval into a Bayesian credible interval and allows you to have a Bayesian and therefore a more informative interpretation of the confidence interval. The strongly enthusiastic prior was specified just like David Spiegelhalter described it being specified. So the probability of observing the treatment effect used to plan EOLIA was specified to be 50%, and the probability of harm was only 5%. At the other end of the spectrum, we specified a strongly skeptical prior. In this case, we felt like specifying a low probability of an absolute risk reduction of 20% wasn't actually skeptical enough. Many people would say that's actually impossible. And so we used it as a boundary for skepticism, a sort of previous classic trial of in the field of ARDS where the absolute risk reduction was around 10% and designed the prior to represent the probability of having an ARR 10% being very unlikely. And so the other priors were intermediate to this, basically, where most people actually fall in terms of their true beliefs, enthusiasm or skepticism for the therapy. But the basic idea was that if we could adequately represent the range of belief, enthusiastic and skeptical, then we could allow people to form their own conclusions about what the EOLIA trial signified in terms of its implications for their clinical decision making, regardless of where they started. One of the nice techniques is that you can actually turn your prior into a kind of theoretical randomized trial by comparing how much information would I need, given the amount of information specified in this prior, how many patients would I need to study in a randomized trial to be this skeptical or this enthusiastic. And so, for example, the strongly skeptical prior, represented by the light green distribution, was equivalent to a previous randomized trial enrolling 264 patients and finding no difference in mortality. And given that that would be a much larger study than any published to date and larger even than Eolia, we felt that this was actually a very reasonable degree of skepticism to be applied to the data. We also used priors that were derived from previous data, and this was a technique that I learned from George, where you basically can take the previous data, apply, combine them in sort of your usual random effects meta-analysis style, but then actually apply different levels of weight to represent how confident you are in these data. So as you downweight these studies, basically it's like you're allowing each patient in all of those previous studies to contribute, say, 50% information or 25% or 10% information relative to a patient in Eolia. And this allowed us to sort of compensate for the significant methodological limitations of the previous studies in terms of a lack of confidence in their findings. So the other problem is that the actual minimum clinically important difference for ECMO is also highly controversial. And some people think, even just given what's at stake, somebody's life, that even any mortality benefit is potentially important. Whereas other people argue, well, given the public health sector investment that's engaged and the kind of centralization and effort and labor and cost that goes into it, and also potentially the potentially significant long-term disability and quality of life attached to surviving severe ARDS, maybe the minimum clinically important difference needs to be much higher. And so basically to satisfy anybody, we specify a whole range of potential values for the minimum clinically important difference, both in terms of relative and absolute risk. Some of these were just actually requested by the JAMA editors. And so we were just doing that to satisfy them too. But personally, I thought that an absolute risk reduction of 2% would be a reasonable minimum clinically important difference, because that would be equivalent to about 500 lives saved every year in the United States, given the number of patients they have with severe ARDS, et cetera. So something in that range, in my opinion, is a reasonable minimum clinically important difference, but others might disagree. Some people think 5%. So the analysis proceeds by taking the data from Eolia, computing your likelihood function, combining it with each of your priors to obtain your posterior, and then from the posterior estimate the probability of each of your minimum clinically important different treatment effects for the relative risk or absolute risk difference. So the primary results of the analysis are shown here. So under the minimally informative prior, based on data from Eolia alone without any prior information, the results of the trial found that the probability of any reduction in mortality was 96%, which is, at least from our standpoint, impressively high compared to the kind of level of confidence we have about many of the interventions we apply every day in the ICU. And this becomes a much more informative kind of number to have in your head and in conversations with families and policymakers than quoting a p-value, because it more directly informs the question at stake, which is, should we be doing this therapy or not? So here I show the posterior probabilities for the relative risk of below 1 across the range of priors. So the x-axis here, you've got your minimally informative prior, strongly enthusiastic prior, moderately enthusiastic, and skeptical. And you can see that obviously as you become more skeptical, the posterior probability of benefit becomes lower. But the important thing is here is that even under strong skepticism, the probability of at least some mortality benefit is reasonably high. If you apply this for an absolute risk reduction of at least 2%, and again, you can see relatively high posterior probabilities across the spectrum of priors. And obviously, as you specify more stringent definitions of treatment benefit, your posterior probabilities become lower. Under the various data-derived priors, even when you significantly downweight the prior evidence, the posterior probabilities of treatment benefit remain very high. And so our interpretation of this is that the posterior probability of mortality benefit from the use of early ECMO is actually quite high. But I think the question remains, and is a matter of ongoing discussion as to whether it's sufficiently high to generate routine use. And of course, this is going to depend on consensus on what counts as a minimum clinically important treatment effect, and just how high the probability of benefit has to be in order to command action. That to me is a particularly interesting philosophical question. Just how much evidence do we need in order to justify a treatment decision? And of course, its impact on other outcomes like long-term quality of life in survivors. And so one potential approach to drawing all these issues together could be to perform some kind of decision analysis, and that is now underway. So we basically talked about all of these issues here, the various advantages of Bayesian analysis. One of the interesting things that came out of our trial is that between the time when Eolia was originally published in the New England Journal in May, and our Bayesian analysis was published in October, there was a lot of discussion about, oh, we need another trial, we need another study to decide whether ECMO really works or not. And I think in follow-up to our presentation of these posterior probabilities, the consensus now is that we don't actually, no one would do another trial of early ECMO and severe ARDS because equipoise is just not there anymore. And there's a growing consensus in the field that this is the right thing to do in properly selected patients who've been managed and cared for correctly before considering ECMO. One of the important limitations of this analysis was that it was post hoc, conceived the idea after the study was published. I wasn't involved in the original trial. But I think a couple of things to be sure is, A, we just basically replicated the primary pre-specified analysis plan just using a different statistical framework. And the other thing is that given the likelihood principle under Bayesian analysis, repeatedly looking at the data is less of a concern. And really the most important issue when you're evaluating a Bayesian analysis is whether the priors have been properly and accurately specified or not. So just to wrap up, the question remains, and obviously the most pressing one is, so just when does Bayesian analysis really change your thinking around the results of the study? And I just want to present a couple of thought-provoking studies. One of them here from Dhuminda Wijayasundara, who probably many of you know, published this nice paper in the Journal of Clinical Epidemiology about a decade ago. And he conducted a systematic review of parallel group randomized trials published over a 10-year period in sort of 4 of the major clinical journals, and compared the results obtained from a Bayesian analysis to those obtained from frequentist analysis. And the plots here basically summarize the posterior probabilities of different thresholds of treatment effect in positive trials and a negative trial. So if you look first at the plots on the left, the positive trials, here he's applying 2 priors to these data, a non-informative prior and a skeptical prior, because you remember that the goal of a positive trial is to convince a reasonable skeptic. And so you can see that if taking any relative risk or hazard ratio to be evidence of benefit, then the posterior probabilities in these positive trials are very high. But if you're skeptical and you're convinced that a much more stringent threshold counts as real treatment benefit, and the posterior probabilities are actually considerably lower in many of these trials. On the other hand, in the negative trials, where he employed non-informative and enthusiastic priors, in many cases, particularly with the enthusiastic prior, the posterior probabilities of benefit were high enough that a reasonable enthusiast would not necessarily be convinced by the trial that the results were wrong. Probably where Bayesian analysis and frequentist analysis are most likely to reach different conclusions is when in the first case you have a very large signal, but too small of a sample size to have convincing level of power. And on the other hand, a very large sample, but a very small effect. Bayesian interpretation, those 2 situations might be different from the conventional kind of interpretation. I was struck, I've sort of now started looking at studies from a Bayesian standpoint, And I was struck by, this is just one random example here, a recently published study in CMAJ looking at the risk of autoimmune disorders after HPV vaccination. And of course, the goal of the investigators was to establish whether or not HPV vaccine is safe. And their conclusion was that it, in fact, was they did not observe an increased risk of autoimmune disorders following HPV vaccination among teenage girls. If you look at the confidence intervals for many of those associations, and including the one overall, if you were to give a Bayesian apply a minimally informative prior and apply and of course the question would be whether or not that's appropriate, and interpret these confidence intervals in Bayesian terms, the conclusion is actually quite different. Is for some of these disorders, it seems more probable than not that an autoimmune disorder would result from vaccination. So really what one wants to ground one's conclusion of safety in is a very low posterior probability of an increase in the risk of an autoimmune disorder. And this study actually doesn't demonstrate that for some of these disorders, in my opinion. So I think this is an example, again, of where a Bayesian framework is going to force us to rethink very carefully the ways in which we reach conclusions and decisions in clinical medicine. All right, so my overall conclusion is that I think, and I think George agrees, that posterior probability of treatment effect or association resulting from Bayesian analysis can be very helpful in the interpretation of research findings. And my own view is that I think it would be useful for every trial to report both the results of a conventional frequentist analysis and a Bayesian analysis in order to assist with the understanding of just what the data mean for one's clinical practice. Lots of great people that I get to work with, both clinically and methodologically, and I just want to acknowledge the massive amount of work that George did on our Bayesian analysis, and really it's such a pleasure to collaborate with him and with everyone else. Thanks very much.
I have time for questions, so fire ahead.
Any violent disagreement?
No, on the contrary, I think you're down a very appropriate pathway here. I'm always very strongly influenced by my time at McMaster with Sackett. I don't know if you know, the head of surgery at McMaster was, he died recently, Barbara Mueller. He's the guy that finally persuaded surgeons about the stupidity of radical mastectomy. And he used to teach in the ClinEpi program at McMaster. He said repeatedly, I think you'll like this, any chance he got, he said, we were talking statistics and significant values. A difference to be a difference has to make a difference. Mm. And he kept saying it, and his point was that that whole analysis, which becomes a bit better, I think, as you're headed with your work there, but it still means nothing except in relation to how you set the end result on which you're going to base your statistics. Mm-hmm. Does it include quality of life data? Does it include duration of effect? Does it include adverse events? You know, in the classical situation at the moment, there's all these medications that have a 40% chance of giving a woman with breast metastases an extra 3 months of life. It's reaching the point of absurdity. So you shouldn't even be discussing the result, in quotation marks, of testing a substance or a medication or whatever without looking at these other factors. And in the end, the subjectivity comes back into every one of them.
Mm-hmm. Yeah.
And that would be interesting to somehow get a hold of the subjectivity.
Yeah. Yeah, and I think it's interesting, one of the letters that was sent to JAM about our paper complained about the subjectivity of Bayesian analysis. Oh, you could have, you know, you can do this with any trial, make turn into a positive trial if you just specify an enthusiastic enough prior. That's the kind of, but I think that kind of thinking is simplistic because you cannot escape the role which judgment plays in good science. You know? We make judgments about what counts as a good design. We make judgments about whether there are biases that need to be addressed or not. You just can't quantify all those things. Robots can't do science. You know, people have to have judgment, and this is to me, a way in which Bayesian analysis forces you to make these kinds of judgments and explicitly as part of your analysis, particularly about a minimum clinically important effect. And then from there, you know, the analysis proceeds. So to me, Bayesian analysis is really statistics for clinicians. And I think the editorial in JAMA for our paper sort of spoke to that when they talked about clinicians releasing their inner Bayesian. So
just from that point from Bayesian analysis being that for clinicians, I was just wondering if you could take some reflection as whether or not there's been a registry to self-establish for ECMO, and whether or not there's a need for, when you have technologies like this that are not used frequently, to develop a disease registry to allow for you to capture what happens in real life of the events, so that you actually can apply a Bayesian analysis in a clinical aspect to evaluate new technologies. And then if you believe on using it, you use it. But if that actual Bayesian approach to the registry tells you not to, then you change your belief, right?
Right.
And has that been considered for things like ECMO, and especially within an ICU critical care environment?
Yeah.
So you actually create a national registry within a disease state to look at these technologies to evaluate what you should do with them.
yeah, so there is for ECMO, there are registries. The case data that I showed at the beginning is derived from an organization called the Extracorporeal Life Support Organization, also, and they have a large international registry where all cases of ECMO get registered. And then, and many of you will know Eddie Fan. He's actually developing a new registry that will have a lot more granular detail in the management and so on to address some of these issues.
Are those disease registries or ECMO registries? So the challenge is, by creating a technology registry, you do not have a data set of comparators when you make the choice not to use the technology. So therefore, the data set itself is only telling you what the technology is doing, not how clinicians have variation in managing disease. And so therefore, all ARDS patients would be the ones evaluated, and then you can then glean where you made a selection to the technology within that data set, or having a comparator that allows for value. So is it just for the device, or is it?
Yeah, those registries in particular for patients in whom the device is applied. There are large health services registries where people do like sort of sub-analyses of ARDS specifically. I'm not aware of an ARDS specific registry. Okay. Eddie might know of one, but yeah, I mean, of course, your point is well taken.
It comes with TAVI and other technologies. We create registries tied to the technology,
right,
not to the disease state where we can get variation in management practice.
Yeah, it's very interesting and new material for me. I guess my question is, does the legitimacy of your conclusion, is it influenced if you perform a Bayesian analysis on a post-hoc basis? Does that make a difference, given the fact, I mean, I think this is always a concern that predefined subgroups, that, if you don't, are you just going to be fishing to make the data reach the conclusions that you want, if you're doing it on a post-hoc basis?
Yeah. So, that's a really important issue, and one that was a major threat to publication. Apparently at the JAMA editorial board, there's a lot of controversy about publishing a post-hoc analysis of a trial. But the truth is, I think that that's really because we're so used to concerns about the risk of type 1 error when you do unplanned repeated analyses of data. And that's really a problem for frequentism. It's not a problem for Bayesianism, given the likelihood principle. The real issue is, does having the data change your prior? That's really the problem. Like, so for example, there are empirical methods for specifying priors to represent sort of the consensus belief in the field about the effect of the therapy that you can then use in the design of your trial. We had no way of doing that once the data was published because, everyone's prior is not going to be influenced by EOLIA. So you can't do that. But nevertheless, I think we found ways to represent what reasonable enthusiasts or skeptics would have believed before the publication. And as long as your priors are appropriately specified, then you're not at risk of drawing incorrect conclusions, because the data are the data are the data.
that your priors aren't going to be influenced by the results of a frequentist analysis?
Oh, well, this is the thing. I don't think, because we specified them the way, for example, that Spiegelhalter described, representing what a reasonable enthusiast would say based on how the trial was designed, the effect size used to plan the trial in the first place. And the other thing is we had data-derived priors that incorporated data from, previous studies down waiting for their limitations. So yeah, clearly that's the vulnerability, are the priors specified correctly? But if somebody thinks that their priors weren't specified correctly, then I think that they would be legitimately concerned about our findings. And I would welcome that, those criticisms, but we genuinely thought that, a reasonable skeptic or reasonable enthusiast about ECMO would have beliefs that look like this. So
that same reviewer made one point. I'm not sure you saw if the reviewer knew how good the comment was, but he suggested that the prior might not be the prior for ECMO, but for a treatment for severe ARDS. So, if you don't focus on ECMO, you say, well, there are different treatments. How do they work? This is just one of them. So the prior for a treatment for severe ARDS is a universe of treatments, not just this one.
Right.
And also said, a good rebuttal to this, would you have done this if the trial had been positive? To try to show that it didn't work. Well, maybe you wouldn't, but someone else might have done that. So someone else could have taken this approach, showed, well, the results are marginally positive, but they're not convincing enough to people who don't think it works.
Yeah. Yeah. No. And I really think the letter writer's concerns were well taken. That this was just somebody decided to do a Bayesian analysis because they didn't like the results. But I think if we're right, then this should be done every time as part of your design, and I think it's just as much more informative to know the probability of benefit from the therapy than it is to know the p-value. I mean, there's no comparison in my mind about what actually informs clinical decisions. Great.
Okay.
Thank
you very much, Ian.
Thank you, George.
Thank you. That's great. The HPP. Yeah. People just like colonize. Work.
Yeah.
And because they also cover one, they say they don't have.
Yeah.
Have to do a
And I thought, I was like, I should